Okay.
Good afternoon. I'm Dr. Pat Roach. I am a psychiatric mental health nurse practitioner, faculty, and the program coordinator here at SUNY Poly. And it's my privilege to welcome you to today's doctorate in nursing practice project presentations. Our DNP candidates have spent the past several years integrating advanced clinical knowledge, leadership, quality improvement, and evidence-based practice to address real-world problems in healthcare. Each project you'll hear today reflects months of rigorous scholarship, collaboration with clinical partners, and a deep commitment to improving patient outcomes and strengthening our systems of care. These candidates have demonstrated the highest level of practice expertise, innovation, and professional integrity. Please join me in congratulating them on reaching this milestone. It is now my pleasure to introduce our first DNP candidate. Up first this afternoon is Haley Sapanic. And Haley, would you go ahead and introduce your project and a little bit about yourself and your project, and then go right into your presentation, please?
Sure. Hello, my name is Haley Sapanic. I'm both a family and psychiatric nurse practitioner. I work in Fonda, New York for Gloversville, for Nathan Latore Hospital that's in Gloversville. My project today is, I'm going to share my screen. All right, so this project is very near and dear to my heart because it surrounds all the things that I have been focusing on for the last 9 years. And it really, everything that I've learned in this doctorate program, I was able to apply to this final project. So my project is called Transforming Patient-Centered Medical Homes, Implementing Trauma-Informed Care to Achieve the Quadruple Aim. It is estimated that approximately 80% of all adults in the United States have a history of at least one traumatic event within their lifetime, with 60% having experienced their first traumatic event before the age of 18. Trauma exposure is directly linked to poor physical and psychological health outcomes and predisposes individuals to somatization, thus increasing primary care utilization. These patients require a patient-centered approach, allowing them to make decisions. Primary care is typically the first point of contact for these patients. However, healthcare providers lack the training required to care for these individuals in a comprehensive, trauma-informed manner. Trauma-informed care is a healthcare approach that emphasizes the importance of acknowledging the impact that trauma has on an individual, recognizing signs of trauma, responding in a trauma-informed manner, and avoiding re-traumatization. The patient-centered medical home model was developed to address challenges commonly encountered in the primary care delivery system in pursuit of the quadruple aim. Patient-centered medical homes strive to create a patient-provider relationship that empowers patients to participate in their own care by actively involving them in care planning. However, there is no standardized approach to achieving this level of care. Rural communities face significant barriers in accessing healthcare, especially mental health services. These communities tend to have lower educational attainment, higher levels of poverty, and an increase in exposure to several forms of trauma. Unlike their urban counterparts, rural communities tend to have poorer health outcomes, lower life expectancies, and are more likely to suffer from chronic illnesses. The quadruple aim of healthcare focuses on improving patient outcomes and satisfactions, decreasing healthcare costs, and enhancing the provider experience. It is observed that any failure of one of the four aims will lead to a failure of all of the aims. Being trauma-informed goes beyond just the relationship between the provider and patient. It extends that understanding to all people within the healthcare system, fostering meaningful connections and creating a safe space for choice and collaboration. My research question is, for patient-centered medical homes, does the integration of trauma-informed care, compared to current practice lead to improved job quality and a greater sense of teamwork among providers. Nathan Latour Hospital and Nursing Home is located in Gloversville, New York. It is a 74-bed rural acute care hospital with 12 conveniently located primary and specialty care centers that serve Fulton and Montgomery counties as well as the surrounding areas. Nathan Latour has taken pride in being a standalone community hospital that has provided high quality care for over 100 years. Nathan Latour Hospital is a patient-centered medical home. However, many of the primary care providers and specialty providers within the organization operate as standalone entities and adhere to the traditional medical model of paternalism. Care coordination is lacking, interprofessional communication is poor, and there is little shared decision making. My problem statement. In 2024, Nathan Latour Hospital and Nursing Home conducted an employee engagement survey and found that only 33% of the staff were highly involved and enthusiastic about their work. Best practice organizations typically have a 72% engagement level, meaning they are have more than double the number of engaged employees. The survey revealed that employees feel a lack of recognition, do not believe the organization cares about them, and are disconnected from the mission. These are all features that are consistent with provider burnout. This quality improvement program incorporates trauma-informed care and the guiding principles of the patient-centered medical home as a framework for achieving the quadruple aim with a focus on provider satisfaction. Our sample is going to include all ambulatory care providers, meaning all outpatient providers that work at Nathan Latour Hospital. They'll be invited to participate. This will include nurse practitioners, physician's assistants, medical doctors, and doctor of osteopath. My project aims include improving job satisfaction among providers, improving the sense of community and teamwork among providers, and increasing the knowledge of trauma-informed care with an increase in self-reported competency. The data will be collected using primary data collection. All participants will be surveyed pre and post implementation. The outcomes will be evaluated using a paired t-test for each of the 4 screening tools to determine if the interventions were successful. The long-term evaluation will consist of comparing the results from the 2024 Employee Engagement Survey to future surveys. This measure will continue to be evaluated over the next 5 years to determine the sustainability and success of the cultural change. The 4 screening tools that I will be using are the Trauma-Informed Care Provider Survey. This will evaluate the provider's knowledge, opinions, and self-rated competency regarding trauma-informed care, recent practices, and barriers to implementing trauma-informed care. The Professional Quality of Life Scale is a series of 30 questions to evaluate compassion satisfaction, burnout, and secondary trauma stress. The Teamwork Perceptions Questionnaire will assess readiness or a need for culture change initiative and post-implementation to evaluate the progress towards enhanced teamwork. The Teamwork Attitudes Questionnaire will also be used pre and post implementation to assess the process towards improved teamwork attitudes. My implementation consists of 6 interventions. The first one consists of the education piece. There'll be education provided to all clinical and non-clinical staff throughout the primary and specialty care clinics. This education is going to include specific education about what a patient-centered medical home is, because many providers and staff members within the organization do not realize exactly what a patient-centered medical home is and how it's supposed to function. There'll be information on the quadruple aim. There'll be a significant amount of trauma education, including the neurobiological and neuroendocrine effects of trauma, adverse childhood experience scores, trauma-informed care, communication techniques, and team building. There will also be education on evidence-based self-care methods. I'll be implementing an end of the shift checklist. It will serve as a daily self-care activity for all staff to reflect on their day. It will encourage them to release any difficult emotions that arose, identify what went well, and do more of that, and ensure that their colleagues are okay. The checklist also encourages all staff to leave their work behind, focus on their personal life, and rest and restore their energy. We will be holding quarterly provider luncheons for networking, collaboration, and to discuss quality improvement opportunities and for peer supervision. Another intervention that we have is the organizational commitment statement. Nathan Latour Hospital is committed to the cultural shift by integrating trauma-informed care as a framework at every level of the organization. The organization will remain person-centered, strengths-focused, and inclusive. As a trauma-informed organization, it is our duty to realize the widespread impact of trauma and understand the impact that trauma has on a person's thoughts and behaviors. Recognize the signs and symptoms of trauma in clients, families, staff, and other individuals. Respond by fully integrating knowledge about trauma into policies, procedures, and practices, and actively resisting re-traumatization of both our clients and staff. We will also be developing an interdisciplinary team or committee, which will be created to increase the trauma awareness, work toward the cultural change, and provide ongoing training and assessments to champion trauma-informed care throughout the entire organization. Additionally, there'll be education pamphlets available in the waiting areas for patients to view at will. This will help to raise awareness about trauma and reduce the stigma related to seeking care. For my timeline, for recruitment, I sent out flyers to all of the primary care and specialty care providers because I think that paper, having an actual invitation, was going to be better than looking at an email. I went and visited each of the sites and I introduced myself and invited each provider to participate in my quality improvement program. After that, for the preparation, we scheduled all the education sessions, met with the leadership team for the rollout, gathered the baseline data and demographics, and finalized all education plans, handouts, and pamphlets. Then November to January will be all of my implementation. After that, the evaluation will be data analysis, outcome assessment, sustainability, and dissemination planning. For my supports, the hospital administration has agreed to cover any expenses related to implementing trauma-informed care based on the cost avoidance strategy of reducing employee turnover. There is full support from the leadership team. All education will be provided during regularly scheduled meetings, which will eliminate additional non-clinical hours for providers and staff and facility costs. All data will be collected using Google Sheets, which will not incur any cost. The costs that we will have include the educational supplies, food that we'll provide during meetings and lunch and learns, and the analysis software. It has been well established that initiating trauma-informed care improves patient satisfaction and outcomes while decreasing healthcare costs. The integration of trauma-informed care into patient-centered medical homes would serve as a strategic framework for achieving the quadruple aim. When an organization transforms its culture, provider satisfaction is rarely the goal. This program is unique because it aims to improve job quality among providers and enhance team communication by utilizing trauma-informed care. Framing the program from a provider satisfaction standpoint will help to achieve provider buy-in, making the implementation easier and leading to sustainability. After completion of the trauma-informed care implementation for primary and specialty care clinics, our plan is to roll out trauma-informed care throughout our entire organization. In May of 26, we are going to launch a community-wide trauma awareness campaign, as that is Trauma Awareness Month. And then in June 2026, the big goal of this entire thing is the integration of behavioral health services within the patient-centered medical home, so that when patients are identified as having trauma and require referrals, they'll have an internal team of psychiatric nurse practitioners to refer to and to consult with. Those are my references. And that's it.
Thank you, Haley. You can go ahead and stop sharing. And at this time, we're going to open it up to questions for 10 minutes about Haley's project. Do I have anyone that has any questions about her approach or project?
Well, if nobody's going to go first, I want to say, Haley, I'm so happy that you're doing this particular project. And I like the idea that you're focusing on the providers here, because they're clearly an important part of trauma informed care. You got to be okay yourself and trauma informed in order to do trauma informed care work. And the question I have, I was a little, and I know that this was a limited amount of time, so you couldn't go through all of the details on how exactly you would implement this. But it was very interesting to me, because we're doing something quite similar in school districts. We're, instituting trauma-informed care, and it's somewhat similar to what you're doing. And I will share with you what we're doing there, because there's a framework that might be very useful to you, that sort of formalizes the educational component of trauma-informed care for the provider here. So it takes the principles of what trauma-informed care involves, the 4 principles, and then puts it into an ecological model. And just clinically, in my own clinical work, that seems to work better. I mean, I borrowed, but this wasn't, unfortunately, my original thought. I just adapted it. I stole it and then adapted it. And the field studies that we've done so far indicate that it's working. So I'd be happy to share that with you.
Awesome. Thank you.
Haley, do you want to say anything about your approach and framework that you're using for education?
Well, so from the education, after doing all the literature reviews, I tried to gather all the data and figure out like what seemed to work best throughout all of the different articles that I read. And the way I'm going to start this program is it's just the regular introduction of what trauma-informed care, just as simple as I stated it here. And then what I'm going to do is I'm going to talk to the whole staff about what the patient-centered medical home is and the guiding principles of that, so that they understand how we're supposed to communicate with each other, how we're supposed to be a team and work better for this community. And then as I go through there, our big thing is that we have different communication techniques. There's talk about like how we're supposed to speak to each other. I did a very small launch in my office because that's kind of where I'm gonna like start. And I was talking to my staff. I introduced them to all the principals. We went through the end of the day checklist. And at the end of the workday that day, one of the nurses came up to me and she said, "Thank you so much for that presentation. My provider was mean to me all day long. And after watching your presentation, she got me a coffee." She's like, "I think it's really going to work, Haley." And so I kind of laughed because it's kind of like, the way I put it to them was, this is like what we've said forever, like don't judge anybody until you've walked a mile in their shoes. So it's not judging people, understanding that we all kind of have our own background, we've all experienced things. And when people are coming at you, in a particular way, instead of being offended by it or upset by it, you really have to consider like where they're coming from, meet them where they're at, and just be there to support them and try to like diffuse the situation the best you can instead of making it worse.
And that,
So
what
it's
you
going to be
just
a lot
said,
about
yeah,
communication.
yeah, absolutely. And communication is part of what makes the safe environment. And that's one of the
Mhm.
key characteristics of trauma informed care is safety. So that makes a lot of sense to me to start there.
Yeah.
Uh, Pat, I have a question. Haley and Morgan and Stacy, again, as I mentioned earlier, this is pretty exciting. Haley, for your particular one, the topic is uh, very important. In fact, I saw Dr. Joe's eyes light up when they talked about, what you're doing. I'm going to ask you a terrible question, and it's actually going to be directed to all three of you, but the other two of you don't have to ask. Anytime you plan a project like this is the most important thing in the world to you. It's not an important thing to other people per se. As you are looking at this process, what could possibly go wrong, and how are you going to uh, deal with that, or what's your plan B, sort of?
Well, I assume that there's going to be definite pushback from providers. However, with our organization, we have very young, innovative leadership, and they are fully supporting this. So, a big part of this is that they ran all my numbers for my patient panel. I see the most patients in the entire organization. I see about 30 to 45 patients in primary care every single day. So we pulled all my metrics and we were able to show that my patients are happy, healthy, compliant, and they're almost never hospitalized. So the way we're going to try to put this off, I also, not to toot my own horn, but I do get paid the most. I'm the highest paid provider, even above all the doctors in our organization. And they said that they will bring that to the forefront so that they can see that this is what works. This is where our community needs to have it. And I have all these patients, not because I'm not good at saying no, but because I'm in it for the right reasons. And this is where healthcare was supposed to be. That's why my last slide was, putting the heel back in healthcare. This is a movement that I feel so strongly about. I am from Massachusetts, lived in Nebraska, came to New York as a nurse practitioner. And when I took this job in this community, I immediately felt like I could make a difference. It's a very rural community. It's generational trauma, poverty, teen pregnancy, substance abuse, and they just need people who care about them. And it's unbelievable. Like I've never woken up and been like, oh, I have to go to work today. I'm like, oh, time to go. Today's the day. So it has brought so much joy to my life, taking care of these patients and developing these relationships with the patients. So I'm really gonna like be able to show them from my experience with these patients. Like I have a huge patient following. My patients are healthy, they're happy, and I make a lot of money. So why not do it too?
Sounds good to me. Any other questions for Haley? Okay, at the end of our program, I will put up a QR code that you can scan with your cell phones for evaluating the entire session. So if you would just hang out at the end of the 3 presentations, I would appreciate that. Okay, we are almost right on time. We're just a few minutes ahead, but if there are no other questions, then we will move on to the next presentation. All right, seeing none, then it's my pleasure to introduce Morgan Hawes. Morgan is our first candidate who will be going from the bachelor's degree to the DNP, where Haley and Stacy both completed our certificate of advanced study and then went on for their DNP. I will say Morgan has worked really, really hard, full time, completing this program. So without further ado, it's my pleasure to introduce Morgan.
Thank you, Dr. Roach. So I'm Morgan. I am a registered nurse currently, and I work at an outpatient mental health and substance use clinic. Just trying to get my slideshow going here. Awesome. So my project title is Translating Evidence into Practice, the implementation of a cognitive behavioral therapy toolkit to improve anxiety outcomes in children within a community behavioral health system. So the problem background is that there's significant mental health disorders among the youth, and those percentages are rising, and anxiety disorders are noted as one of the most prevalent, affecting the school-age children. Many of the young individuals are also more likely to have poor academic adjustments, depression, substance use disorders, high rates of comorbidity, as well as functional impairments, including emotional regulation, school functioning, family functioning, etc. And there is a link as well as individuals that are diagnosed with anxiety-related disorders during childhood are more likely to have comorbidities and challenges during their adult life. So the goal is for early intervention and effective treatment for anxiety-related issues to be done early, and the golden standard is cognitive behavioral therapy as that frontline management for childhood anxiety disorders. The problem is that there's a lack of clinicians who are comfortable with evidence-based modalities and treatment for children and adolescents specifically, and that hopefully by improving clinician competency and evidence-based treatment, it will subsequently improve outcomes for children and adolescents that are experiencing these diagnoses. So in the last year, from March to 2024 to March of 2025, Community Health and Behavioral Services was able to collect data on their current population, and 133 individuals between the ages of 8 and 17 were diagnosed with an anxiety-related disorder. And so that indicated that 16% of their served population was struggling with anxiety-related symptoms and would benefit from cognitive behavioral therapy intervention. The problem is that the 16% of the population is relatively large, and there's a lack of mental health professionals who are confident in treating children with the diagnosed anxiety-related disorders. So that brings me to my PICO question. So we ask, for mental health professionals providing therapy-based services, how does an evidence-based treatment toolkit impact clinician efficacy and knowledge-based pre-intervention compared to post-intervention in providing cognitive behavioral therapy to children and adolescents between the ages of 8 and 17 who are diagnosed with anxiety-related disorders over a 5-week measurement period? So the project scope is the design and implementation of a clinician training program on cognitive behavioral therapy, as well as using an evidence-based toolkit with a focus on anxiety and related disorders for this population. The training topics were identified and reviewed by the agency's leadership team, inclusive of all clinical members. The overarching goal of this project is to increase clinician efficacy and knowledge in providing cognitive behavioral therapy to children with anxiety and related disorders, and that the clinicians will utilize the CBT techniques in therapy sessions using material from the toolkit that will be provided to improve health outcomes for these children. So again, the planned outcomes are to increase clinician CBT skills, as well as improving their treatment modalities that is being used in sessions and improving their overall efficacy and knowledge base, leading to improved child and adolescent symptom improvement. So for environmental context, this project is taking place at Community Health and Behavioral Services, which is a subdivision of Upstate Caring Partners located in Utica, New York, servicing approximately 6,000 unique individuals each year. It is a certified community behavioral health clinic that provides outpatient mental health and substance use support to individuals across the lifespan. So they see as early as infancy up until end of life. This facility is located in Oneida County and surrounds Madison, Herkimer, Oswego County. So there are some individuals that are crossing counties to receive services in this location. The broader healthcare community, the importance of this context is organizational readiness. So this organization has leadership support that supports quality improvement and clinician development initiatives. The existing staff training structure and supervision framework allow for this implementation to be done without major cost. And by utilizing existing scheduled staff meetings, we minimize disruption and allow for training and evaluation to take place. So overall, the project cost is low, minimally disruptive, and highly adaptable, allowing for support throughout the implementation phase and sustainability within the behavioral health system ongoing. This quality improvement project promotes sustainable integration of evidence-based cognitive behavioral therapy practices within this clinical setting by enhancing the knowledge and self-efficacy through a standardized toolkit and training model. The project's design allows for replication across similar behavioral health environments, supporting consistent delivery of evidence-based psychotherapy. The implementation of this project could be replicated across a variety of different programs, school-based programs, other outpatient settings. And so by empowering clinicians with accessible, cost-effective educational resources, this contributes to long-term improvement in mental health outcomes, which align with national priorities for quality, efficient, and behavioral patient-centered healthcare. Our market analysis, Community Health and Behavioral Services is one provider of several in Oneida County providing mental health services. Other providers in the area include Mohawk Valley Psychiatric Center, the Neighborhood Center, Helio Health, ICANN, Mosaic Health, and Clinton Therapy and Testing Center. And that's a rough list. There are others that are not pictured here that are competitors, for lack of a better sense, in this behavioral health market. The reason why community health and behavioral services is a good fit is that there's an internal need and organizational fit within the agency. The project addresses a recognized gap that within the organization, clinicians often lack formalized training and standardized resources for implementing cognitive behavioral therapy. And the gap results in inconsistent application of evidence-based interventions and a variability of patient outcomes. So the proposed clinician toolkit and training sessions directly align with the organization's strategic goals of improving clinical quality, enhancing staff development, and promoting evidence-based care delivery. Additionally, external demand and relevance. So across the broader healthcare market, there's an increasing demand for evidence-based mental health interventions that are supported by governing bodies. The cognitive behavioral therapy remains one of the most cost-effective and empirically supported treatments for anxiety, depression, and other related disorders. So by strengthening the clinician's CBT competence, positions the agency competitively within that behavioral health sector, especially growing public and payer expectations for measurable evidence-based outcomes. 3 is competitive advantage. So few outpatient programs within this community in Oneida County have similar community settings that have implemented structured ongoing CBT models for clinicians. So by developing and maintaining this standardized toolkit, the organization can serve as a leader in this realm, supporting future collaborations, partnerships, and even grant funding opportunities through this dissemination project. There is a variety of risks. So implementation risk could be lack of clinician engagement, limited participation or resistance to receiving new training may reduce its effectiveness. There's also time constraints, competing clinical demands may limit the staff available for the training, and fidelity of the use without ongoing reinforcement from the organization. The toolkit use may decline over time. With that goes organizational risks. Resource allocation, so there's minimal budget or administrative support, which could roll out delay. Thankfully, this project is relatively cost effective. And there's also risk for leadership turnover. Changes in management may disrupt project continuity as well as future ongoing use of the training. So I've created these SMART goals, benchmarks. So one of the goals would be clinician competence improvement. So I have identified a goal of greater than 20% increase in post-training cognitive behavioral therapy competence. Studies show that targeted CBT training improves clinician knowledge by 18 to 30%. I'm also looking for toolkit utilization and fidelity, hoping that greater than 80% of the clinicians who attend the training report regularly using the toolkit resource within that 4-week post-implementation period. Supporting data shows that implementation studies show the standardized cognitive behavioral therapy aids enhance consistency of care and adherence to evidence-based protocols. Lastly, another goal would be participant satisfaction. So I'm hoping that greater than 90% of the clinicians report satisfaction of the training and the toolkit usability. The supporting data shows that high engagement and satisfaction predicts sustainability and program adoption. So the overall implementation is the development of this clinical training, which will be designed with input from the leadership team, directors, clinical supervisors, focusing on cognitive behavioral therapy treatment methods, and creation of this clinical toolkit, which was really the meat potatoes of the project. It provides the tools in order for the clinicians to be able to actively use these in sessions. There will be a series of CBT focus group sessions, which will be held with clear agendas for a total of 4 weeks. And the program will teach and support the development of this project for plans with ongoing incorporation for new clinician onboarding. So this is a snapshot of the toolkit. So the toolkit that I've developed is about 50 pages of a variety of different contents. Again, it's really like the meat and potatoes of my project. It provides the clinician with a variety of facts related to the treatment importance for anxiety-related disorders, evidence-based screening tools, different symptom presentations that may arise, cognitive behavioral therapy facts, CBT structure for the clinician, and checklists to help keep them aligned with the fidelity of CBT in the model, as well as evidence-based worksheets and checklists to incorporate within their sessions and assign homework along with the CBT model. And those aids are inclusive of coping skills, deep breathing exercises, thoughts, feelings, and behavioral worksheets, behavioral activation, exposure therapy, and self-affirmations. And I've even included parent resources, as parent education is a huge component in making this sustainable outside of the clinical office. So there's a lot of information related to that as well in the toolkit. So our tools to measure their clinician competency, I'm using the CBT competence scale questionnaire to help measure their CBT competence and efficacy pre and post intervention. Additionally, we'll be using the electronic health record to obtain the number of children and adolescents between the ages of 8 and 17 currently diagnosed with anxiety-related disorders before and after this implementation period. Part of the training is that I include a lot of information about different evidence-based screening tools. So we're hoping that also by rolling out this implementation that there will be an increase in individuals diagnosed because of the new availability of screening tools specific to anxiety and related disorders. So the marketing plan, internal marketing will be completed by the Director of Clinical Services during their large group supervision meetings with follow-up emails. There was also a variety of flyers that were sent out among the clinical team. Calendar invitations were utilized in conjunction with the emails to help promote engagement in the weekly focus group sessions. So this is my overall project timeline. So we started this in January of 2025, and our end goal would be April and May of 2026. So to break that down a little bit, clinical training and toolkit development is supposed to be completed by December of 2025, leading towards our final analysis and project completion by May of 2026. So the necessary supports for this project include a site preceptor to support all project activities, ensuring outcomes, timeline, and budgets are met, operational support to assist in coordinating the training events, materials, and catering, as well as leadership faculty to evaluate the program training and toolkit prior to the final development and dissemination. Materials overall include pre and post questionnaires to measure the clinician efficacy and competence, the printing of the toolkit, which is provided both electronically and in hard copies to enhance the use, catering, which includes snacks and lunches for the training, as well as the focus group sessions to promote attendance and engagement, and overhead, which includes the lack of revenue during the training periods, classroom space, technology, and related expenses. And to conclude, our dissemination plan, which will be determined in our next course semester, Nursing 860, our DNP project evaluation. And here are my references.
Excellent. Thank you so much, Morgan. And with that, I'd like to open to questions.
Hey, Morgan, I've got a question here. I have to admit, I'm not a nurse. But you had that list of the toolkit content. How did you decide, and maybe I missed it, if I did, I apologize. How did you decide what content to include? Was that based on literature? Was that based on an existing toolkit? Did you get input from providers? Can you talk about that a little bit?
Yeah, so the foundation of the toolkit was developed based off of my literature review, collecting all of the data that other research has been done in implementing cognitive behavioral therapy toolkits and references in training programs. Most of those training programs took place in a school-based setting, so there was some tailoring to make it more of a clinical-based setting. And so for that piece, I obtained feedback from the leadership team as well as the clinical team members who would be responsible to utilize the toolkit, and finding out what they would looking more of and what recommendations they would want included in that toolkit. So that's kind of where I gauged the different topic items.
Great, thank you.
Okay, Morgan, I have just a couple of questions. Number one, I'm going to ask you about your targeted subject pool. You're using all clinicians from community behavioral health?
Yeah, so clinician is anyone providing therapy services to individuals is who is attending the trainings.
Okay. And there's a large variation in terms of those providers, in terms of their background. And because CBT is a methodology that is used very extensively, at least in psychological graduate programs for training, and I believe probably also in social work. So knowing how much they know to begin with is number one. The second question that I have has to do with the kids that because a number of them are going to be duly diagnosed. You're going to have that's number one, and number two, how do you filter the biopsychosocial model here? Because the anxiety, especially anxiety in children, may well be a function of several different factors. So, filtering that out and then understanding how that plays a role and how effective CBT is, and what the impact on the provider might be, or even integrating that into the training for CBT is extremely important.
Yeah,
that
and
we know.
one of the evidence-based screening tools that I talk a lot about in the training is the SCARED tool, which really separates out anxiety into different categories. So it gives you the ability to kind of target your CBT, but there is likely some comorbidity, of course, occurring within the population.
Can you speak to the first part of that question, which is the variability of the background of the providers? Now I understand there's some bachelor's prepared versus master's prepared providers.
Yeah, so there is a variety of provider knowledge base. And so part of the pre-collection phase is incorporating a demographic questionnaire so that I can obtain where the level of expertise lies, as well as what experience they've had in the past. One of the questions that I ask in the questionnaire is, have they had a refresher training on CBT within a 5-year time frame? And many of the clinicians that have responded to the pre-screening did not have a any type of CBT related training or refresher within that 5-year time frame, although that they've had masters prepared and it was included in their coursework. It wasn't something that was ongoing that throughout their professional career.
Other questions? Okay, so seeing none, Morgan can take a deep breath. We'll connect you with Joe to maybe iron out some of that question about the biopsychosocial model as part of your final project for next semester. And then we'll move into Stacy. Stacy is presenting today on health literacy. So Stacy, if you'd go ahead and introduce yourself and then your project.
Good afternoon, everyone. I just want to say first and foremost, congratulations to Morgan and to Haley. You guys did a fantastic job. We've been on this journey together, and it's been great. So we're really excited about presenting to you all today. So my name is Stacy Flannery, new to some, well known to others. I'm a family nurse practitioner. I'm a double alum of SUNY Poly. Happy to be here. I chose to get into this program because I wanted to really be able to provide comprehensive care to my patients. At the time when I started this program, I was a sole provider of a clinic, and I couldn't get through a visit without tackling a mental health component that really made it challenging to manage the comorbidities of my patients. So this program has given me the ability to do that. So moving into my project, I hope you all can see my screen. The topic is on health literacy. Taking a little bit of a different direction, but you might see some parallels with Haley's. It's going to be looking at a little bit of a culture shift. But the title of my project is Implementing the Brief Health Literacy Screen During the Rooming Process to Identify Patients at Risk for Low Health Literacy. And this is a quality improvement initiative to make health literacy the sixth vital sign. So getting into that, most people, when they hear health literacy, they zoom right in on the key word of literacy. They're automatically thinking about reading and writing. But health literacy is more than that. It is actually a Healthy People 2030 directive. It's been a major consideration really since 2010, since the National Action Plan came out, looking to address health literacy and how it impacts patients. So health literacy, it is a national priority within the Healthy People 2030 landscape. And the goal is to eliminate disparities, achieve health equity, and improve health literacy to enhance the well-being for all. But just to really give a really simple definition of health literacy is, what do you do with the information that you receive? Can you read a prescription label? Do you understand what the doctor just said? Can you follow directions for the care that was given to you before, after leaving the office? It's not directly correlated with your level of education. So it doesn't matter how smart someone is. It's about how well things are explained. If patients don't understand, that's not their failure. It's on us to make it clear. So my goal is to really put health literacy at a forefront, to look at it as if we're looking at a blood pressure, and taking that into consideration when we're caring for our patients. When we look at health literacy, there's a fork in the road. There's the personal health literacy, that's one's ability to find, understand, and use the information to make well-informed decisions about themselves. And organizational health literacy is how organizations are providing an atmosphere for patients to do that. So objectives from Healthy People is looking at increasing provider communication checks for understanding, decreasing poor communication, improving patient involvement. We know that engaged patients tend to have better outcomes and overall raise overall population health literacy levels. So just to go a little bit further, just so you know a little bit more of what I'm referring to, this is an actual scenario. A 2-year-old is diagnosed with an inner ear infection and prescribed an antibiotic. Her mother understands that her daughter should take the prescribed medication twice a day. For carefully studying the label on the bottle and deciding that it doesn't tell you how to take the medicine, she fills a teaspoon and pours the antibiotic into her daughter's painful ear. Now, if someone were to hear this, they wouldn't automatically think, oh, she's got limited health literacy. They would probably think otherwise, that she's not smart or whatever the case may be. But this is a real life example of what limited health literacy can look like. On a more extreme end of things, there's a scenario, which these are real life scenarios. A 29-year-old African American woman with 3 days of abdominal pain and fever was brought to a Baltimore emergency department by her family. After a brief evaluation, she was told that she would need exploratory laparotomy. She subsequently became agitated and demanded to have her family take her home. When approached by staff, she yelled, "I came in here for pain, and all you want to do is an exploratory on me. You will not make me a guinea pig." She refused to consent to any procedures and later died of an appendicitis. Few issues here. An appendicitis, if treated and caught in time, can be treated. It should have very low mortality. The word usage in this condition, exploratory, automatically triggered the patient. Going to Haley's examples of trauma-informed care, that elicit a trigger for her. And just looking back in history, there have been some poor medical mishaps or exploratory, I guess you could say, on minority populations, which is, tapping into that cultural competency. So this is just an example of what limited health literacy can look like and the implications and why it's important. In this case, it was the difference between life and death. So just to give more context here, bringing this to light, had the pleasure and have the pleasure of currently working with Union Community Health Center, which is a cornerstone institution in the Bronx, New York. Just to give information about this area, the Bronx is a beautiful place. It is multicultural, it is multilingual. However, it is the last county out of New York's 62 counties ranked for overall health and well-being. There's a lot of social determinants of health that point to chronic illness and comorbidity, increased poverty rates, housing instability, and environmental stressors. Again, pointing back to that trauma-informed care. But other indicators that we look at is obesity rates, self-rated health. 23% of the population rate their health as fair or poor. And that's actually higher than state averages. Child poverty is 35%. Hospitalizations, highest age adjusted rates in New York State for heart disease and diabetes. Other disparities, children in the Bronx are twice likely than citywide numbers to be hospitalized. So as you can see, this is an area that has a lot of health disparities, high utilization of healthcare expenses, and social determinants of health. So the implications is that these outcomes underscore the urgent need to strengthen health literacy, preventative care, and culturally responsive communication in the Bronx community. The problem here, limited health literacy, as we noted before, it can be linked to health outcomes. And it profoundly affects patient outcomes, correlating with increased hospitalizations, as we saw, poor chronic disease management, medication errors. This has also been linked to poor follow-up, poor treatment adherence. But what's really disturbing is that 9 out of 10 US adults encounter difficulty utilizing and applying complex health information. That's 90% of people who have challenges here, which underscores the broad scope of the national challenge. So limited health literacy is a substantial public health crisis, directly influencing patient adherence and overall health status. The Quality Improvement Initiative directly addresses the organizational need within a high-risk, underserved population, which is served by Union Community Health Center. Current UCHC data revealed that only 63% of patients felt they received health information that explained in a way that was easily understandable, indicating a substantial gap. However, this data was obtained, but there was not a benchmark to understand, was this a good outcome or was this a bad outcome? But this is something that we're looking to understand and to create a benchmark for. So the PICO question here is, in adult patients receiving primary care services, does implementing the brief health literacy screen during the rooming process as a sixth vital sign compared to no standardized health literacy screening tool identify patients at risk for low health literacy? This is important to look at because Union Community Health Center is a federally qualified health center, and their mission is to advance equity that necessitates adopting a standardized approach to identifying communication barriers. But this project scope is realistic because the brief health literacy screen, it is brief. It's a 4-question survey, and it facilitates integration to an existing clinical workflow. And the data that we will collect from it will directly inform targeted patient-centered communication strategies. A little bit more about this location. Like I said, it's a cornerstone in the Bronx. They have almost 40,000 unique patient visits per year, almost 200,000 patient encounters annually. They have over 100 medical providers. They have multiple satellite locations. So as you can see, they are a staple for this community. However, this patient population experiences a lot of socioeconomic disadvantages and often confronts barriers to navigating the complex health system that we have here in the US. The absence of standardized health literacy assessment currently contributes to patient communication gaps, as we saw with the 63% only saying that they understood the information that they received. So integrating a brief health literacy screening tool here supports the overall mission of creating health equity, increasing access, eliminating barriers, providing information to those multi-generational households. If we can provide understandable information to one, they can take that back home and then they can also infect the rest of their community. Oh. The evidence supports the use of the brief health literacy screening tool. But just to back up a little bit further, has not actually been declared a single tool that should be used over another. There are multiple tools out there that have been validated. And the way in which I came to use this tool, just to give a little backstory, I was actually looking to use a different tool called the National Vital Sign. The newest vital sign, I'm sorry, and it was looking at a food label, and it could tell you someone's numeracy, their ability to apply other aspects of that information from a food label, and how they make information about their health. In the midst of working with the center from January till late summer, we got the call that a patch was able to be added to our EMR system for a health literacy tool to be added. So we came upon the brief health literacy screening tool. So the literature provides robust support for implementing a rapid health literacy screening tool alongside provider communication training. The brief health literacy screening tool was selected due to its brevity and feasibility, allowing for seamless integration into high volume primary care settings without creating excessive rooming time. This is super important. Anyone who has experience working in a federally qualified health center, providers are busy. They're tasked with seeing patients every 15 to 20 minutes. It has to be something that can be done quickly so that they're not falling behind. And this is an essential ethical consideration to prevent workflow disruption and minimize clinician burden, which can lead to intervention failure, as we know. The project moves beyond simple screening by mandating a plain language and teach-back intervention for at-risk patients, directly applying to establish efficacy of educational strategies. Provider training is crucial because studies show that providers often fail to apply recommended communication techniques like teach-back, even when they recognize the need to adjust for low health literacy. Often in provider charts, you'll see the verbiage, patient verbalized understanding. But what does that mean? Was that patient actually adherent to the treatment plan that was discussed? Well, the organizational commitment is key to making health literacy and cultural responsiveness systematic and sustainable, transforming the care environment itself rather than relying on individual provider motivation. So this is an organizational plan here that encompasses screening our patients at the time of rooming and also providing providers and the medical staff training on what health literacy is, what does it look like, what are cues, and how to intervene. So the objective here is starting out is, let's start screening because at this time we have no benchmark. So looking for an 80% completion rate. Right now, just focused on primary care patients that are adults 18 and older. Obviously, screening can be waived if someone's coming in absolute duress or if there's cognitive impairment that's obvious, that would prevent an accurate screening. But 80% completion rate among all eligible adult primary care visits. The short-term outcome is to increase the proportion of screening and identification of at-risk patients identified with limited health literacy. Because we're going from a zero standardized screening to now standardized implementation of a screening tool. An activity is using their built-in lunchtime to provide a lunch and learn, and also provide micro refresher huddles and sessions to just again remind people about health literacy. What is it? What does it look like? I'm a firm believer in that you have to meet people where they are. So you have to make the stories resonate with them. Because this is not only adding a screening tool, this is also looking to shift a culture and looking at health literacy as it applies to each patient situation and using that as a part of judgment and how you determine future care plans for your patients. Long-term outcomes is increase the identification and documentation of patients at risk through screening, resulting in provider communication practices, therefore, which should inform us to be able to create more targeted patient education, more targeted patient campaigns, for instance, to increase preventative screenings. So this has a big potential for long-term outcomes. And the evaluation piece, because this has already been embedded into the EMR system, we're able to, do chart reviews, we're able to run reports and queries to look for the workflow, to look for the percentage of completion, documentation of interventions, and also checking in for qualitative data as well to see if there's a perceived burden amongst the staff and providers. So this is just an example of what it looks like currently in the EMR system. They utilize Athena. It's a 4 questions a screening tool. It is administered by staff, so this is not something that's given to them out in the waiting room. It's administered by staff, just like the staff would be administering a blood pressure. As you can see, this is how the score can be interpreted. In this particular one, the score was 10, which means this person landed in a limited portion, meaning they're not able to read most literacy health materials. They may need repeated oral instructions. Materials should be composed of illustrations or videotapes. This gives providers and encourages providers to really tap into that kinesthetic teaching mode. Sometimes you might have to draw a picture for your patient to understand. Most medical literature and patient education handouts is written at a 5th grade level. With anybody who has a 5th grader, they may be reading novels, and a lot of our patients cannot read a novel. So we have to make the information plain, clear, and use plain language and take the shame out of it. Put the burden on yourself as the provider to say, hey, you know what, I just want to check to make sure I gave you the right information. Can you tell me in your own words what it is that we discussed or recommended for your care? That's a good way to, see if your patient is hearing and receiving the information that you need them to receive. So how does this, apply, in advanced, nursing practice? Well, as a DNP, we are tasked with taking research and infusing that into evidence practice and infusing that into our clinical settings. So the DNP role here is providing expert judgment to select a brief, validated BHLS tool, ensuring practice relevance and feasibility for a fast-paced primary care setting. We're using systems thinking to integrate the screening into an existing EMR and workflow. And the initiative integrates ethical and health equity considerations, utilizing also the toolkit from the AHRQ, which is a health literacy toolkit, which discusses many of the interventions that I've been dropping along the way. Leadership was demonstrated by coordinating multidisciplinary staff training and obtaining buy-in from medical directors and staff, and really integrating organizational culture change. I would say that's one of the challenges because we're doing a shift. We're shifting in how we're approaching our patients. And we're now taking this additional thing and taking into consideration. Because at the end of the day, we really should try to figure out why our patients are lagging behind. Why are there disparities? And this strategy moves beyond simply identifying the deficit to addressing the deficit or the disparities, but it looks at addressing the root cause of why some of these disparities may happen. And it could be just because of limited health literacy. The project promotes scalability and sustainability because it's already embedded into the EMR system. It's a minimal risk tool embedded. So it allows for effortless expansion across all of the practice sites post-pilot. Okay. So implementation plan. This is a quality improvement plan. So we're following PDSA cycles to refine the workflow and address emerging barriers in real time. We're doing that with huddles. Also frequent check-ins, chart reviews, working with QI analysts to get chart extractions. Also using change management planning as well, addressing potential staff resistance by emphasizing, the value of the screening. A lot of times people don't resist because they just want to. They may just not know. They may not understand why this might be an added value to their practice. Primary evaluation measure includes the completion rate of the screening. The documentation of teach back or various communication interventions in the charting by the providers. The AHRQ Universal Precautions Toolkit. This is the framework that I'm using to provide information as far as on how providers should communicate with patients. We want to assume everyone may need help understanding, so it's universal, regardless of who the patient is that you're speaking to. It emphasizes using plain language, slowing down, focusing on key points, confirming understanding through teach back, showing and not just telling, and creating a shame-free zone. So the implementation plan is logically linked to the objectives, focusing on the process, measures to drive necessary behavioral change. For instance, the screener completion rate directly measures the adoption of the workflow. And the use of PDSA cycles allows for rapid iterative adjustments, ensuring the process is efficient for both staff and patients. So this is just an implementation Gantt chart. I have been working with this site since January, but we got things off the ground early October. So looking at a 12-week cycle, first few weeks is really just providing that education, trying to get that buy-in. 8 weeks after that, really focusing on the screening and consistently getting those screenings done, at least an 80% rate. And afterwards would be the review of data, because I really do think we can make some great correlations with this. And supports and budgets, just like the other candidates said, the cost has been low to no. The organizations have been absorbing the cost, and the screening tool is already embedded in the EMR, taking full advantage of the lunch breaks and times or whatnot that the staff have to provide lunch and learns and huddles or whatnot. So additional staff time is not needed. The key personnel, which is medical director, director of nursing, chief technology officer, and QI analyst, who was readily available for me to outreach, to get data, to do chart abstractions. And we also have the use of in-house printing services. If there's any additional costs, it's maybe my travel to the Bronx or whatnot, but it's very minimal. So for as far as dissemination plan, I know that we will get more into this in our Nursing 860 course, but the primary objective will be to disseminate amongst the organization as a whole, hoping to get this rolled out across the entire site, all the sites attached to Union Community Health Center, perhaps in a grand rounds format, and being able to, especially once we're able to get all of the data and to make, correlations, I think it will be very powerful. There are obviously other journals that we can submit to for publication and disseminate to all. And that is my presentation.
Thank you, Stacy. At this time, I'm going to open the floor to any questions for Stacy on her health literacy project.
I've got of course, I've got a question here. But Stacy, nice job.
Thank you.
Like Morgan, I see she has a couple family members here. I see somebody related to you is here also.
Yes.
And I know Doug York is thrilled at having this project. I know he's been wanting to do something like this for years. So I want to ask you a question about on a little bit on your methodology. You mentioned that your goal is to get 80% completion, correct?
Yes.
Okay. What if you don't get 80%? Would you accept 75%?
Yes, I will.
Would you accept 60%?
And I know 80% is aggressive right now. There's just no benchmark. There's no baseline.
Okay.
So ideally, in this pilot phase, to try to screen everyone
Okay. Well,
coming in.
the point I'm trying to make here is how many patients go through that clinic do you anticipate during that time period? 1,000, 500, 10,000, 50? Do you have an idea of what approximately how many people will be there?
Sure. So I'm currently doing this at one of their satellite locations. So this facility on average weekly has at least 120 patient encounters.
Okay, so let's just
Yeah.
say make
So
it
we'll say
100. Just say 100. So
yes.
and how many weeks are you going to be collecting this particular data?
8 weeks.
Okay, so you're looking, hopefully, let's say you get 100 on the average, 80%, that's what 80 times 8, what, 640 or something like that. I think you
Yes.
might be better, instead of putting 80%, you may want to put down, a minimum number that you're maybe looking at, because what would happen if you only have 50 people coming in this week and only a third of them are doing it? Just you're putting yourself in a kind of an awkward situation. So, you may want to talk it over with your advisor and just see if you can clarify that a little bit more. 80% seems to be lofty. It may be acceptable, but you may also find out that if they're there with kids and, that may be the last thing they need to fill out, as important as it might be. And so you may want to look at like a minimum number you'd like to strive for, or and percentage is nice, but just something to consider. And if
that's
you don't
one of the
get that
nice,
number, if you
and
don't
that's
get
one of the
those
nice
numbers, now
parts
you
of
may
this
want to
screener.
expand it. What's that?
Yeah. I said that's one of the nice parts of this screener. It also has an option as to why it wasn't done.
Okay. So anyway, this is exciting. You're going to have a great data. My congrats, Dr. Reed, for over working with you on this. So good luck.
Yes. Dr. Roach, looks like you have your hand up.
Yeah, I just want to say, Stacy, I think you're being very humble in your project. Stacy overcame
Yeah.
great lengths to get any buy-in.
Mhm.
Despite having support at the top, there was a disconnect between the top and the actual screeners. And the support was completely lacking up until about 3 weeks ago. So she's really pulled this together, tremendous effort. And we've tried all summer and then into the early fall to get this project launched. And it really wasn't until the last few weeks that she was able to launch it. So I just want to mention your tenacity and the fact that you didn't give up, you didn't throw in the towel, working with Dr. Reed and myself, you were willing to change course and to really change things up. And that really speaks to you as a student, you as
Thank
a
you.
person, and you as a nurse practitioner. So I want to give those kudos there.
Thank you.
Yeah, and I just enjoyed your presentation. And I'm thinking to
you.
myself, she'd be the kind of provider I want to see in terms of all of your basic ideas and your values here and the way you approach. You are truly patient-centered. And you're so right about this health literacy issue, and your case studies are, I've seen them myself. I've seen examples of what you're talking about. So I think you're right on. And health literacy is probably something that we need to pay more attention with. So kudos to you.
Thank you. I appreciate it.
Any questions for Stacy? Any questions for any of our 3 DNP candidates or their faculty advisors?
I don't have a question, but I just want to make a comment. I think that all 3 of these presentations were very well done. So congrats to all of you.
Yes, I'm very proud of this group.
And we want all 3 of you to be at graduation. Okay,
Oh, I'll be there.
it's important, but it's also important to your family that you're there too.
Yes.
Absolutely.
And your Mama Bear faculty.
Yes, we will be. I will be. It's on the calendar.
Counting down already. So
Awesome. Okay, if everybody will hold on just a moment, I'm going to share the QR code to complete the evaluation. And I again congratulate our 3 candidates and thank our faculty who's worked with them, and look forward to the final step in this project implementation and evaluation next semester.